Thank you all for joining in with the Scleral Lens Education Society's last webinar of 2025. I'm going to give everyone a few minutes to kind of trickle in for tonight's webinar. We have a really exciting one doing a Scleral Lens research update for the entire year with Doctors Maria Walker, Gloria Chiu, and Vivien Say. I'll go ahead and get going a little bit of their bios. Dr. Walker is here at U of H here in Houston. Dr. Chiu is at USC Roski Eye Institute, and Dr. Say is over at Berkeley, University of California. Here are disclosures. They'll go a little bit more into their background in a moment. Many of y'all have already been on our webinar, so probably understand the Q&A feature, but I'm sure there'll be a lot of questions. So if any questions pop up about any of the research studies, anything throughout, we'll do all the questions the last 10 minutes. So definitely stick around for that. You'll just use the Q&A feature and submit your question. And at the very end, we will go over them with our panelists. Do keep in mind that if you're trying to get your CE credit, which I'm sure lots of people are trying to get that end of the year, you have to stay on the minimum of 50 minutes. You don't have to stay for that last 10, but you're welcome to go over Q&A. You'll also get a QR code at the very end that you can scan, go directly into your app and the OE tracker. But if not, the CE certificates will be emailed in 2 weeks. But without further ado, I'm going to transfer over control to our lovely doctors to go into the research. Thank you guys for being with us tonight.
Thank you so much for having us. So, I am going to go ahead and introduce everything for tonight. And I'll say right off the bat, this is such a wonderful kind of becoming a tradition. This is, I think, the fourth or fifth year I've done this. And this is the second year that I've been joined by Vivien and Gloria, who I have both known for years. And I love reading their publications. And really, the whole point of tonight is to really just do an overview of all, we're going to pack in a ton of the scleral lens research that's been coming out over the past couple of years. So we'll look at global trends, we'll look at different sort of clinical long-term and short-term outcomes and talk about maybe how they kind of influence our thought process and how we actually are taking care of patients. And then we'll talk about some of the sort of different, there's been some publications on some sort of unique applications of scleral lenses, and we'll talk a bit about some just really how this research drives our evidence-based decision-making strategies. We are all clinicians. Vivien and I are both research clinicians, kind of half and half. I think maybe a little bit more research, and then Gloria is in the clinic, but somehow manages to publish all the time. So uh, we can go forward, yeah. And we always kind of look at this is just the standard graph from PubMed. We always just kind of get a sense of how many publications are coming out each year. So we've kind of plateaued a bit. There was 25 new publications in 2025, and we actually are going to go through just under 30 studies today. And there's lots of different countries represented. It's going to be very quick on some of them. We'll take a little bit more time on some, but lots of different countries, the Netherlands, Australia, India, all around the world. Of course, there's quite a bit done here in the US as well. So, just to start us off, and then I'll pass it to Gloria, there was a paper. So, this is a paper that came out in 2024 with Efron and his crew looking at international trends in rigid lens prescribing. So, just general trends. And really, the general findings here is all rigid lenses increased slightly from 2020 at about 14% to 2023 to about 15% of all lenses that are fit. And then representing 20 scleral lenses representing about 30% of all of the fits worldwide. So if we look, there's a graph that shows sort of the proportion of lens fits. So these are all the different countries, and then that big black one in the middle that looks more bold, that's the median. And I literally spent about 15 minutes. You can go back for just a second, Viv. Yeah, I spent about 15 minutes trying to find the US line in there, and I realized it basically tracks exactly underneath the mean. So, like most things, the United States falls about the mean of all countries, so about 10 to 15% of all lenses. And as we saw, yeah, 15.2 in 2023. If we look at the next figure, this is just showing the percent. So if you advance one, you'll see we kind of block out the different, the green there is representing the scleral lens proportion of all rigid lens fits. So somewhere in like Portugal, they're fitting a lot of rigid lenses, 80% of their rigid fit or scleral lenses, 80% of their rigid fits are sclerals. And then in the United States, we're at about 40%. So and then, like I said, worldwide, about 30%. So that's just the general trends in rigid lens prescribing. I'm going to pass it to Gloria to actually talk a little bit more about a bibliometric study that looked a little bit more specifically at where some of these publications are coming out from.
So, on the theme of international trends, I thought this was a very interesting paper that essentially looks at what we've been doing with scleral lenses over the past 50 years. So, this paper is bibliometric and visual analysis of scleral contact lenses and really looks at global characteristics and research trends from 1976. So, the objective of this study was to gain insight into future research directions, and it's interesting to note that they took data from the Web of Science Core Collection, or the WOSCC database. They included almost 500 articles from over 500 institutions across 38 countries. Of note, the United States and Australia led in frequency. There were over 1,300 authors identified. I think many of you listening tonight are included in this list. And just a few kind of shout outs here. Vincent Stephen had the highest number of publications. Dr. Deborah Jacobs had the most citations. And the Journal of Contact Lens and Anterior Eye emerged as the primary publisher of studies here. And just a couple of kind of prevalent keywords that were most utilized were keratoconus, scleral contact lenses, management, contact lens, scleral contact lens, ocular surface disease, dry eye, and contact lens. So I wanted to show some of the nice visual analysis that they provided in this study. And this was a flowchart of literature selection. You can see it was kind of low in the 1970s through about 2005. And then suddenly we saw a gradual increase. Peaked right around 2020. I think maybe we got bored during the pandemic or had extra time at home. A lot of papers came out during 2020 and then kind of tapered off again. In the next figure here, we see a rank of all the affiliations, and Mayo Clinic is at the top from the United States with almost 600 citations and 34 articles. At number 2, we have the University of Houston, where Dr. Walker practices, and many of our Scleral Lens Education Society directors have come from. And then we have Australia, mostly from the United States in the next couple ranks. We do have the LV Prasad Eye Institute, which is in India. Not sure why they list United States there, but maybe there's some affiliations with partners in the United States. In the next graph here, this figure essentially highlights a lot of the most productive authors. So you might be able to see in there, if you're looking carefully, your name. But Dr. Walker is definitely there, along with many of colleagues that I have so much respect for, who have brought so much insight into the scleral lens community. And then in the next figure here, we have the next table. It just lists the top publications with the most citations. And of note, a publication that came out of Boston Sight by Perry Rosenthal in 2005 discussed fluid ventilated gas permeable scleral contact lenses as an effective option for managing severe ocular surface disease and corneal disorders that would otherwise require penetrating keratoplasty. And I think that was really a turning point in ophthalmology, because we realized, ophthalmologists, optometrists, that these scleral lenses could delay or prevent the need for cornea transplantation. And I think that's really a change in how we manage our patients now. Now, going into the next slide here, a couple of limitations were that the data from this study relied on information from the WOSCC, not necessarily Scopus or PubMed, so maybe some articles were excluded. Also, inclusion criteria centered around studies published in English. Maybe there was a language barrier. But in conclusion, scleral contact lenses were the pioneering type of contact lens and still remain heavily prescribed today. Globally, the USA leads in research, and Mayo Clinic does have the highest number of publications. The majority of articles originate from internationally influential journals, and most of our publications discuss indications, materials, fitting methods, and outcomes, and potential complications. So we're continuing to learn a lot there. And this study, I'm not going to go into as much detail, but this bibliometric and visual analysis study looked at a decade of scleral lens research, and it really kind of aligns with the previous publication and really hammers out the point that we're seeing increased utilization of scleral lenses, increased research, and increased fitting. So it's really been an exciting time for all of us. Now we're going to go into another topic of the fluid reservoir. And here we're going to discuss a couple of papers, particularly looking at here slit lamp findings in scleral lens wearers with and without subjective fogging. And the objective here is to determine whether fit characteristics and biomicroscopic findings in lens wearers contribute to fogging. So they looked at 48 habitual scleral lens wearers who wore lenses in one or both eyes from 5 different sites. Now, interestingly here, participants self-reported if fogging was experienced. And they looked at the fluid reservoir, fit characteristics, and also surface non-wetting. So the lens surface in addition to the fluid reservoir. And what they found here on the next slide was that in this population of patients, mean age of 49, with majority indications for corneal irregularity followed by ocular surface disease, fogging was reported by 58% of the participants. Of note, all the patients used preservative-free single-use saline. The mean time of using these lenses was about 15 months, wore them about 12 hours per day. They had to wear the lenses for 2 hours before they presented for this study, and they found no significant differences in fitting characteristics in eyes with and without fogging. They looked at things including limbal clearance, landing zone, edge impingement, edge lift, and conjunctival prolapse. They also noted that the fluid reservoir depth didn't really play a role in the fogging. So some people say, well, decrease the fluid reservoir, there'll be less, or maybe too high of a vault will lead to fogging. Well, they didn't find that here. But what they did note was that the presence of front surface non-wetting and diffuse haze was statistically higher in eyes with the fogging. So maybe the fogging isn't all from the fluid reservoir, but we should be paying attention to the lens front surface as well. And in the next study here, it looks at the fluid reservoir again, but specifically in patients with keratoconus. So this study was done out of Istanbul, Turkey, looked at 44 eyes of 22 patients with keratoconus, all in 15 millimeter lenses. And essentially, they put one lens on the right eye with preservative-free sodium hyaluronate solution, so a little bit thicker with more, a thicker solution. And then those on the left eye were all with preservative-free saline. After the fitting, they looked at both high and low contrast visual acuities at several time points and calculated the optical density with anterior segment OCT. In the next slide here, the results demonstrate that the high contrast vision didn't really change over time in either the high viscosity or low viscosity groups. However, low contrast vision remained stable during 8 hours in the high viscosity solution, but low contrast visual acuity decreased at the 4th and 8 hours in the left eyes, which were the ones using only the saline, not the high viscosity solution. So this kind of indicates possibly that high viscosity sodium hyaluronate solution may sustain improved low contrast visual acuity in patients with keratoconus compared to those using non-preserved saline. So interesting for us to note, maybe we should be recommending potentially solutions that are thicker, like Celluvisc or other comparable drops, to help with low vision contrast. Next slide here. Now I'm going to turn it over to Maria to discuss midday fogging in more keratoconus patients.
Yeah, so kind of on that same thread, talking about what does the research show in terms of what helps and what doesn't. So I have so many comments about the filling solutions. We're doing a similar study that's showing, regardless of what outcomes you're looking at, it seems to be at least some improvement, but that's for another day. So this was a study done by Root and her group out in Portugal. And what they were doing is they were looking at if you remove the lens midday, so kind of related to debris in the fluid reservoir, what happens. And so they really they looked at three different things. They did a couple of different studies. I'm going to talk about one and then just touch on another. So in this first one, they looked at fluid reservoir thickness, the pre-lens tear film quality, and visual acuity. So they were looking at the tear film quality, and then you can see the OCT there is what they used to look at fluid reservoir thickness. But essentially for their methods, they did keratoconus patients, a couple different groups. They wore the lenses for 2 hours, removed the lenses, soaked them in Boston, and then reapplied them and reevaluated those metrics. This is just to share that they controlled for lens design and material. So what did they actually find? Well, if we look at the tear film scores, and if we zoom into this table a little bit, you can see that the tear film score quality and the two sort of bars, there's squares around the two sort of columns that you want to pay attention to are with the lens on for 120 minutes or 2 hours. So they're measuring these first three, TFSQ, TFSQ area, and auto T-butt. Those are all coming from the Medmont sort of tear film metrics. And so for TFSQ and for TFSQ area, a higher score indicates a worse quality of the tear film. So you can see after they took off the lenses, soaked them in Boston again for 30 minutes, they rinsed them with saline and then reapplied them. They did see some improvement, a significant improvement in those tear surface quality metrics. And then, of course, T-butt, we know the higher is better. They also showed that the high and low contrast VA improved a little bit, but really not clinically significant. The other thing is they looked at the OCT to look at the fluid reservoir thickness. You might hear my dogs playing with their toys in the background. But what they saw was that the fluid reservoir increased, and this makes sense, right? We all know if you take off a lens and then you put it back on, it's not going to settle typically down to the exact same spot. So they did find that the fluid reservoir increased about 40 microns after reapplication, and you can see that in the second line of that table there. And so really the take home here is that you're not seeing, you see a little bit of change to the fluid reservoir thickness, but if anything, it improves when and visual acuity improves, and the tear film quality kind of improves when you reapply it. And if we look at the next, I think there's another, so this is another study that's most of the same authors, but this is actually a separate study. So I think there's some overlap, but the numbers weren't exactly the same. So it's not the same study, but it's a similar design by the same group. And in this one, they were looking more specifically at high and low contrast VA. And then they had this metric called the light disturbance index. If you look at what they actually found was significant, well, the low contrast VA, they saw significant improvement after that midday removal and reapplication, as well as, again, the fluid reservoir was thicker. And so, again, really the conclusion from both of these is the fluid reservoir thickness thickness increases a little bit with removal and reapplication. That's really the only quote negative thing. So sometimes in clinic, we're wondering like, well, if you take the lens off, we always kind of argue, if you take the lens off midday and put it back on, is that helpful? Does that actually improve surface quality? So this actually wasn't looking specifically at midday fogging in the tear film fluid reservoir, but did find, if you take the lens off, as we kind of know anecdotally, and put it back on, you do get an improvement in a lot of those outcomes. So then there's another study. Another study looked at diameter of lenses, and I'll go through this one really quickly. This was just a study that looked at 15 versus 16 and a half millimeter scleral lenses. They looked at acuity, they looked at the amount of lens settling, and then they looked at the optical density of the fluid reservoir. And they used, Uriel Shornack has a protocol for looking at the turbidity of the fluid reservoir using the pentacam. So if you look, and I'll just kind of go through these pretty quickly because again, there's no difference. This is the graph showing visual acuity. So improves with scleral lenses, but does not change, is not different between the 15 and the 16 and a half millimeters. They also looked at lens settling, just like the other study, or that study looked at the difference in lens thick and fluid reservoir thickness. Here they looked at lens settling. So they found, as we know from other studies, about 100 microns of settling with both the 15 and 16 and a half millimeter lenses. And then they also looked at the optical density or the turbidity of that fluid reservoir. And again, here complicated graphs, but no difference. And no difference between the lenses. They do see a slight increase in the turbidity after 4 hours of lens wear, but it was not different between the 15 and 16 and a half diameter lenses. So changing diameter, at least among 15 to 16 and a half, doesn't appear to have an impact on objective midday fogging kind of fluid reservoir turbidity. Here's another study that looked, and this one was some of our friends in India and Australia to really better understand the fluid reservoir turbidity in ocular surface disease specifically. So you can see this image here where they looked at, they took OCT images and then they looked with image J. And what they were measuring is the number of particles as well as the average particle size and the percent of turbidity. And if we just kind of move quickly through this one, you can see that's what it looked like when they measured it. And then they looked, again, just kind of like touch pointing on these studies. This was a study that looked at 13 patients. Really, the take home is the fluid reservoir turbidity increased and reduced contact sensitivity, yes. But, and if we look at the next figure, you can really see that after 1 month, those numbers actually started to get better. So they did see, again, an increase in the turbidity on all the turbidity measures. But then 1 month after the patients were wearing lenses, we saw those numbers start to rebound back up again. And most of us know that even with these slight reductions in contrast sensitivity and increases in turbidity, the lenses are still much better than without. So if we look at these next two studies, I know are for a lot of people a little bit heady. So I'm just going to kind of refer people to them, but sort of show the big highlights. This was a study that looked at proteins, and they looked actually at proteins in the tears with patients wearing sclerals as well as wearing corneal GPs. And they looked at hyperemia as well as using basically mass spec to look at the proteins. So if we look just quickly at what they found, this is just showing that their groups were pretty equal. They had some with sclerals, some with RGPs. Yep, you can keep going. And then if you look at just the hyperemia, no differences in that, which is nice. And then if we look at the protein, so here we're just looking, they just list they did find that there was several proteins that were more expressed in the scleral lenses than the corneal GP lens wearers. If you're a gene aficionado, you might recognize some of these. Zinc finger protein, that one's in keratoconus a lot. But if you move just to the next one, we'll see the other top 10. Yep, you can go to the next one too. Yeah, and then this is just the final on that, just showing that they did find some inflammatory pathways were upregulated in sclerals compared to the corneal GPs. The NF-kappa B complement B cell signaling pathway, as well as some of these FC gamma mediated pathways. So what this really means, we're going to kind of look at this reactive oxygen species, and then I'll kind of give you my quick 2 cents. But if you look here, this was a study where they fit 24 patients with sclerals. They collected their basal tears as well as the fluid reservoir and looked at reactive oxygen species just using a standard assay. If we, yeah, go forward. Yeah. So, and if we just highlight here, really at the top, they were looking at acuity, comfort, and Schirmer's. They saw acuity improved. Schirmer's didn't really change much. The bottom is really the little bit more interesting part. So they basically found that their tier baseline reactive oxygen species, it went up slightly, but really didn't change very much, and actually was about the same in the fluid reservoir and then was less in the fluid reservoir. So really less reactive oxygen species within that fluid reservoir compared to the basal tiers. So really the take home between both of these studies is that maybe we have some inflammatory mediators and debris that can increase, but there does appear to be, and we see this study after study, some adaptation, and this becomes kind of less inflammatory. And we see this with other things too, like swelling and all kinds of interesting outcomes as patients wear the lenses more. So now I'm going to kick it back over to Gloria to talk about some of the clinical outcomes, and then we'll move over to Vivien.
Sounds good. So really quickly, when I was name dropping earlier and I was saying who had the highest number of publications, I meant to say Stephen Vincent, not Vincent Stephen, just so you know who that is. Apologies for that error. All right, now moving on to what can we do with these scleral lenses in treating ocular surface disease? And this paper that came out about a year ago looked at the PROS device as a drug delivery device. And this evaluated the scleral device as a tool to deliver preservative-free cyclosporin 0.05% for dry eye disease. This intention is to increase drug cornea contact time and increase bioavailability and potentially efficacy as well. They looked at 14 daily wearing patients, and all had dry eye, but 7 of the 9 had ectasia. These patients were instructed to put 1 drop of this cyclosporin in the reservoir before preservative-free saline, wear for 6 hours, remove, and then repeat the protocol for at least 4 more hours. So minimum of 10 hours a week. They looked at these patients at baseline 1 week and 1 month to look for changes in their signs and symptoms. The results were that at 1 month, they found a slight improvement in the OSDI, and no change in VA. So they did see some improvement in fluorescein staining, conjunctival lissamine staining, and conjunctival hyperemia. And this demonstrates essentially that this delivery system was well tolerated, and it was really the first in a prospective trial. Larger studies are needed, but this is really interesting because I know myself off-label. I've used topical antibiotic in the fluid reservoir for persistent epithelial defects. We've seen studies that have put anti-VEGF drops in the fluid reservoir for corneal neovascularization and inflammation. So I do believe that there is, some role for this in the future to help with drug delivery. The next study here is a case study and looks at using a piggyback scleral contact lens system in a patient with Stevens-Johnson syndrome. This is a 21-year-old female, a nurse, so kind of lots of interaction with the public, had severe ocular surface changes at age 4. Now, what they did was they noted first that, yes, the prosthetic type tinted lens in medium brown, it certainly helps to improve the cosmetic aspect, but using that alone, it dried out. There was fluting and curling and a lot of deposits that developed. So they put a scleral lens in 16 millimeter diameter on top of the soft lens, and this improved stability of the soft lens. and it was recommended to change the soft lens every 3 months. They only followed this patient, and reported it after 3 months, wore 6 hours a day. And this is certainly something we may consider ourselves in our patients with dry eye. We might consider this piggyback system with a scleral lens on top of a soft lens. In the next study here, it also kind of brings up an area of potential controversy. Sometimes we ask, would you fit normal corneas with just high refractive error in scleral lenses, given the cost, the time, the solutions required? This study that came out of an medical eye hospital in China evaluated scleral lens wear on vision and ocular surface parameters in patients with myopia but regular corneas. 80 subjects participated. Most of them had normal or only mild dry eye, and they fit them with either a scleral lens or a rigid corneal lens for 3 months. The same provider fitted these patients and the same protocol with solutions and care. They looked at vision as well as many different parameters: pressure, vision, tear meniscus height, non-invasive tear breakup time, staining, meibomian glands, and also different aspects of the ocular surface. To judge their symptoms, they used the OSDI and the NEI, National Eye Institute Visual Function Questionnaire. In the next slide here, these are some tables that highlight some of their significant findings. If you can't see all the numbers, don't worry, I'm going to walk you through it. Essentially, when looking at the OSDI, after 3 months of wear in the scleral lens population, they did find some statistical significance and improvement in the OSDI. Looking at the tear meniscus height, going back one, tear meniscus height as well as the non-invasive tear breakup time, they also did find a little bit of improvement in scleral lens wearers after 3 months, but it was pretty mild and not necessarily clinically significant. But in the next slide here, it shows the results that some quality of vision values in the scleral lens group improved from baseline to 3 months, but not in the corneal lens GP group. As we saw in the two tables, the tear meniscus height and non-invasive tear breakup time showed a small increase in scleral lens wearers from baseline, and they did not find a comparable change in the corneal gas permeable wearers, but they were pretty low values. And also at the 3-month point in the scleral lens wearing patients, they saw an improvement in both the OSDI scores and the NEI VFQ. So in conclusion, short-term scleral lens wear did provide good correction in patients with myopia with good visual outcomes without negatively impacting ocular surface wettability. I will say though, in that study, because they only followed the patients for a few months, is that enough time to really consider complications like neovascularization, limbal thickening, or edema or scarring? Maybe it wasn't long enough, and maybe we need to look a little bit further. But it is interesting to note that in the short term, these patients did have improvements and good vision. Now, this study here, I think, is really relevant to all of us. Looked at cost and benefits of specialty contact lenses for both irregular corneas and ocular surface disease from the patient perspective. So this paper came out of India, looked at over 200 patients, mean age of 28 and 60% male. And the primary diagnosis was irregular corneas. So they looked at the benefit cost ratio. They calculated this using results from the NEI VFQ 25, and they converted the results to what's called a quality adjusted life years, or QALYs. And in the next slide here, the results demonstrate that the total median cost for a patient to obtain any specialty lens, so both combined, either corneal or scleral, corneal separately and scleral lenses, was respectively about $700, $260, and $1,300. So costing less for those in corneal lenses more for those in scleral lenses. And these costs took into account health evaluations with their doctor, procedures, lost wages for travel, because we know that it takes a lot of time for these patients to come in and see their doctor. So in general, more days and time were required for scleral lens wearers. And they did find an improvement essentially, and that there was a benefit cost ratio calculated as gain in productivity with contact lens use. And they found that the QALY, the gain, was about $1,600 for corneal patients, $1,800 for scleral patients. In conclusion, that these lenses, despite the time and cost, were cost efficient and led to a gain in productivity, essentially given their improved vision. So good to know for all of us fitting these lenses. Now, we looked at trends in fitting scleral lenses in general globally, but this was an interesting one that looked at a 21-year retrospective review that came out of Needham, Massachusetts, offering PROS treatment. They looked at 209 pediatric eyes, pretty split between males and females, more ocular surface disease patients. The mean time at treatment initiation was 10 and a half years old, plus or minus 2 years. And important to note here is that candidacy for scleral lens wear included feasibility of application and removal by Guardian. And I truly believe that we can't be successful scleral lens fitters by just designing a good lens that fits well on the eye. If the patient can't utilize it, then we failed at some point. The training is part of our treatment. So essentially, 147 eyes or 70% continued to wear lenses at the time of review. Mean duration of lens wear was 8 years, and 8% discontinued wear due to challenges with application and removal. And a couple more findings here. They did find improvement in visual acuity, and very interesting. You would think in young patients that you needed to fit smaller diameter lenses because their eyes are smaller. But actually, it was quite the reverse here. They actually found that there's a mean increase of 1.3 millimeters in diameter over time and ended with a mean final diameter of 18.2 at the last time of evaluation. Remember, in these patients who started their fitting at 10 years old. So conclusion here, scleral lenses are a viable option for the pediatric population. Determining candidacy is important, and the diameter can go a little bit bigger, which may improve overall comfort and stability. So I'm going to turn it back over to Maria to discuss long-term outcomes of scleral lens wear in patients with keratoconus. We're going to go back a few slides. I think we're going forward
Yeah.
too quickly.
No, that's perfect. That's perfect. I'm just gonna skip. Actually, I'm only gonna talk about this one, Vivien, and then I'm just gonna hand it over to you. This was just really cool because this was a patient who actually had all these surgical procedures, and this lens was actually fit during this. They had a MK, and then had to have an emergency transplant, and they basically used it to prevent the eye from just if auto visceration, so like entirely contents expelled. So this was just an interesting sort of almost intraoperative use of a scleral lens. So if anyone's interested in this, you can go read this paper. And then with that, I think Vivien, I would love to hear about some of the stuff that you are doing, and I think you've got some interesting papers that you will go over. So I'll pass it back to you.
Hi, hello, hi, thank you, Maria. So today I'm going to be talking about research scleral lens research focused on three main areas, which is ocular surface morphology, intraocular pressure, and steric exchange. So starting with ocular surface morphology, scleral lenses interact with multiple anterior ocular structures, particularly the upper eyelids where the
Vivien,
meibomian.
sorry to interrupt you. Are you advancing the slides? I just
Yeah,
want
I
to.
am. I am.
Oh,
Particularly the upper eyelids where the meibomian glands are located. So, okay, so this leads to the first study I'm going to be discussing is comparing the meibography images across three groups. The first groups included 34 eyes from 20 habitual scleral lens wearers with keratoconus. The second group included 31 eyes of keratoconus patients, and the third group included 31 healthy eyes. Now, both of these second groups are control groups that do not wear contact lenses. So the researchers analyzed two parameters from the meibography images, looking at the percentage of meibomian gland loss and the presence of gland curling. So you see in the top figure on the left, the red arrows is highlighting the areas of the gland loss in the upper and lower eyelids, while the bottom figure shows the red stars marking the curled glands. So, the study found that the Scleral lens group has significantly greater meibomian gland loss in both the upper and lower eyelids compared to the other groups. And a subgroup analysis of Scleral lens wearers further divided participants based off their history of lens wears. So, more than 3 years versus less than 3 years. So this study concluded that those who had worn Scleral lenses for more than 3 years showed higher levels of gland curling in the upper eyelid and greater gland loss in both of the eyelids. So the next ocular surface structure I'm going to be discussing is conjunctival vasculature. So a research group in China developed a functional slit lamp biomicroscope by attaching a digital camera to a standard slit lamp. Using this system, they were able to capture high-resolution images of the bulbar conjunctiva before and during the 3 hours of scleral lens wear, as well as both underneath the lens and in the area adjacent to the lens landing zone, to evaluate for blood vessel density. So for each of these images, 6 locations were analyzed at every time point, and these investigators were able to magnify these images to visualize individual red blood cells within the vessels and to quantify blood flow velocity and blood flow volume. Additionally, they also took anterior segment OCT images of the scleral lens landing area to assess conjunctival morphological changes and the post-anterior film to grade for fogging. So taking all this information together, looking at it, they saw several patterns. First of all, they saw this increased conjunctival morphological change was associated with higher blood vessel density and slower blood velocity outside the scleral lens, as well as linked to lower blood flow volume, both outside the lens and beneath it. Now, these findings make sense physiologically since as the scleral lens settles onto the conjunctiva, it likely is compressing on some underlying vasculature, reducing blood flow and volume. However, it is important to note that these subjects wore trial spherical scleral lenses and they were not optimally fitted. Interestingly, when all the measurements were illustrated into one figure, as shown in the lower figure, the study found that the fogging grading was positively correlated with blood flow volume beneath the lens. This is indicating that as the fogging is increasing, the blood volume is also increasing, suggesting an underlying inflammatory response. Next, another research group also evaluated conjunctival vasculature and by using the OCT angiography. Now, this study included 13 habitual scleral lens wearers with corneal ectasia. Images were captured across the 4 quadrants, both without and with the lenses. They analyzed 3 regions, the total regions of interest, which is shown in the green in the box B, band 1, which is the blue area beneath the lens, and band 2 is a red area adjacent to the lens edge. The OCTA revealed that the vascular density within the total region of interest and within band 1 in the inferior quadrant were significantly reduced after lens wear. And then next, they studied the OCTA images with slit lamp photographs, which were independently evaluated by an experienced ophthalmologist and examined the potential relationship between the clinical judgment and objective image findings. Now, clinical assessment of the conjunctival impingement was significantly associated with vessel density in the OCTA region of interest in the superior quadrant, as well as with under the band 2 underneath the lens in the inferior and temporal quadrants. So the discrepancies between the clinical and the OCTA finding may be due to the quality of the 2D nature of the slit lamp photographs. So results may differ if the ophthalmologist performed live assessments rather than looking at static images. So now when we're considering scleral lens wear effects, conjunctival vasculature has led researchers to continue exploring its potential effects on IOP, which is one of my favorite topics in scleral lens research. Now, many clinicians still speculate that the large diameter is maybe compressing on key ocular structures, and then this will contribute to elevated IOP. So the first study I'm going to discuss is looking at the changes of IOP over 3 months of scleral lens wearers in 32 Chinese patients with irregular corneas and 28 with regular corneas. So in the irregular cornea group, IOP was measured using the eye care rebound tonometer, while the regular cornea group assessed with a non-contact tonometer. As shown in this top figure on the right, the mean IOP in both of these groups varied by less than zero point 0.3 millimeters of mercury across the study visits, but notably, about 10% of the eyes, which is about 3 eyes in each of the group, showed a sustained IOP elevation of at least 2 millimeters of mercury from baseline across 2 consecutive visits. So even though this 2 millimeter of mercury likely is not clinically meaningful, this finding is supposed to illustrate how many eyes exhibited a consistent rise in IOP over time. But however, there's 2 points that are important to make when we're interpreting these results though. First, the IOP was measured only after lens removal, so it does not reflect the true pressure changes during the lens wear. Second, the use of the different tonometers in the two groups limits direct comparison between them. Next, this research group from Spain has published several studies examining the IOP pressure changes during scleral lens wears, particularly focusing on the effects of different lens diameter. So in their previous work, they measured IOP using the Birkins and the Dowton tonometers. In this study, they used the Oculus Corvus ST to assess corneal biomechanics and two IOP parameters, which is the non-corrected IOP and the biomechanically corrected IOP. So the red circle is showing the small changes in the IOP values, and the red arrows is indicating the small changes in the corneal biometric parameters. So these small changes is suggesting no clinically significant impact. Moreover, the similar changes in the IOP were observed in both of the lens diameters, indicating that lens diameter doesn't influence IOP. In the next study, the same research group also used a sweep source anterior segment OCT to image the trabecular iris angle in 4 quadrants and perform 3D analysis of the anterior chamber parameters, including depth, width, area, and volume. So 16 healthy participants wore scleral lenses of 2 different diameters for 2 hours on separate visits. So the study found that the differences in the trabecular iris angle was only in the superior quadrant. So with smaller lens diameters, the superior TIA increased at a later time point, possibly due to how the landing zone distributes pressures compared to the larger lenses, which tend to kind of hang more down, exerting this downward force, especially during blinking. Additional findings included differences in anterior chamber depth and area between the two lenses, as well as minimal changes in the anterior chamber width from baselines with the smaller lenses. Now, most of these anterior chamber changes occurred with the smaller lenses. So as shown in the figure on the right, the landing zone of the smaller lenses lies closer to the anterior chamber angle than that of the larger lenses. So even with these findings, the researchers concluded that these small changes are likely not clinically relevant in healthy subjects. So the final study on IOP and scleral lenses that I'll be discussing was a 6-hour experiment evaluating changes in the Brooks membrane opening minimum rim width, or the BMO MRW, in 18 habitual scleral lens wearers with keratoconus. So BMO MRW reflects the neuroretinal rim tissue around the optic nerve and has been used in previous research as a structural marker of the optic nerve head as a response to IOP. Now, each of these participants completed 2 sessions, one without the lens wear and one with lens wear. As shown in the figure on the left, there was a statistically significant decrease in the BMO MRW during the lens wearers compared to the no lens wearers. Now, this difference was about a 5.7 micrometers after 6 hours of lens wearers. But what does this 5.7 micrometers reduction really mean in terms of IOP? So it has been suggested that a decrease in the BMO MRW indicates an IOP-driven posterior displacement of the optic nerve head, effectively thinning the rim. However, quantitative interpretation remains challenging. One previous study reported a 0.61 micrometers decrease, corresponding to a 1 millimeters of mercury increase in one IOP. But this study was on non-human primates. while another study in glaucoma patients found ratios ranging from 1.22 to 1.47 micrometers per 1 micrometers of mercury change in IOP. Now, because of these prior studies involves different species and disease contexts, it's difficult to translate this relationship directly to scleral lens wearers and keratoconus. Therefore, while the structural changes observed here appear statistically significant, its clinical significance and direct correspondence to IOP remain uncertain. So my last topic is looking at the assessment of tear exchange during scleral lens wear. Currently, there are three main techniques used in both clinical and research setting. The first one is out-in method, where the fluorescein dye is instilled outside the lens, and we're looking at how fast the dye enters into the post-lens tear film. The second technique is fluorogram, which uses a modified slit lamp equipped with digital camera and specialized filters to assess the fluorescein intensity across the entire post-lens tear film surface. And the final method is the fluorophotometry, which also quantifies fluorescein intensity, but only within a small localized area of the lens surface. So the research group in Australia, working with Stephen Vincent, has developed an alternative method for assessing tear exchange using the eye surface profiler, the ESP from Eaglet Eye. So in this study, a single participant wore a corneal GP lens and a scleral lens on separate visits. The ESP was used to track the changes in the fluorescein intensity over time to quantify any tear exchange during the lens wear. So the figure on the left compared the fluorescein intensity profiles between the scleral and the corneal GP lenses. And as shown in the figure in the middle, fluorescein intensity persists much longer with the scleral lenses, up to 90 minutes, compared to the corneal GP lenses, which demonstrates changes for up to 30 minutes. Now, the figure on the right represents the data from three separate scleral lens wear sessions. And when we're comparing the fluorescein intensity changes to baseline, these three sessions showed consistent results. Now, one important consideration is that about 10 microliters of 2% of sodium fluorescein dye was instilled after the lens insertion. Now, because of this, the ESPN cannot determine whether the early intensity changes, particularly within the first 5 minutes, occurred underneath or above the lens. Nonetheless, since many clinics have had access to the ESP, this technique offers a practical and accessible way to explore tear exchange during lens wear, potentially expanding research and clinical applications.